This is a recording made in the operating room of the operation on a 20-month-old infant for a branchial cleft sinus in the right side of the neck. Following the birth of the child, the mother noticed that there was a small hole in the right side of the neck, and in the past 2 or 3 days, this area has become reddened and swollen. Examination of the child shows a typical branchial cleft sinus, which is a outpouching from the pharynx or windpipe. The operative procedure will excise this swelling, which is infected and draining. It appears that this is a localized thing. Maybe get close.
Like to get a fine gold in.
160.
Spread, cut, spread, cut.
Well, this is slightly different, I think. Yeah.
How about this upward extension?
That's where it goes.
Yeah. It doesn't go down, though.
We haven't.
Doesn't seem to. The skin doesn't retract away in that. When you pull the skin down or pull it up, it doesn't need to be fixed inferiorly.
You can tell when you cut through this stuff whether it's involved in this thing or not. It doesn't go down. You can see it here very clearly.
Yeah.
All right, we'll keep working at it. No, not that way. Spread and cut. Spread and cut. What are you scared of? Well, I mean, what have you got to hurt there? How could you get in trouble?
Oh, not in trouble, just opening the cyst.
Stay still.
Yeah.
Stimulate the right vagus and the left cardiac accelerator. You can send the patient.
Spread, cut. Spread, cut. Now you're beginning to cook. You're getting through your deep cervical. There, now. That's my boy. There. There you go. Yeah.
Shall I stage it?
Of course you're going to stage it. As you dissect it, you get this freed up here, see? And then you get the thing going up. And you just keep dissecting it, coring it out as we go up. Now these things stay up close to the object you're removing. You never get in trouble. Right?
Say more word about a bradycardia.
Get close to the object you're removing.
They go from bradycardia
Good fellow.
tachycardia.
Now, let's get this freed up down here. No, you don't need to do that. Free it up down there, right down to the cyst. Once you get down to the thing, you'll go hopping along again. Spread and cut. Spread and cut. That's baby. Now you're cooking. These are a lot of fun. Once you get down to the track, there you are. Now you're getting down to things. Spread and cut. Working. That's a boy. Spread and cut. If you know your anatomy, you know whether you're going to get in trouble or not, you know? All right, now you can feel this, see? Feel it.
Yeah.
All right, just keep working.
Goes up a ways.
Well, it goes all the way up. Now what we'll do is we dissect it down here as far, stay close to the object you're removing. We dissect it here as we go up until we get to the upper portion, and then what do we do? Better ask Dr. Where does the track follow?
Up to the pharyngeal wall, isn't it?
Well, that pharyngeal wall is an awful big place. You have the pharyngeal wall, you have an anterior, a posterior, and a lateral. All right, where's it go?
Lateral.
Between what structures? It's anterior in the neck now, and it goes, posterior wall is posterior. Now, where does it go? Stay close to the object you're removing.
I'd like to be sure of the spinal accessory when I come up to it.
You have been past it for some time. Let's go. Come on, Doctor.
What muscles does it go between?
How does it go down? How does it get down the pharyngeal wall? It's got to go down there somewhere. Where does it go when it goes down? Hmm?
I don't know.
It goes between the internal and external carotid.
Goes right to the bifurcation. That's right.
Under the posterior
Keep
belly of the
working.
digastric.
Now you dissect up this way. You can usually do it through this stage with traction if you've got a good firm track until it begins to go down. Then we'll make an incision a little higher up. We'll snake this thing up through, and then we'll work it down to the pharyngeal wall. See? See what you just did?
Well, you know.
Give it to the
I just want to see it.
better.
Lou,
Yeah.
we're going to crack a nitrous tank, so don't jump out of your skin.
I will. Why do you do those things in here in the middle of an operation?
Specimen.
Grab the damn thing with something. No, not with the scissors. All right. Here, hold on now. Hold on. Hold on. Now, you've reached the limit here. Now, you want to, there's the tip of your
Yeah.
forceps here, see?
Mm-hmm.
Now the bifurcation, there's the angle of your jaw, right?
Mm-hmm.
Now, goes right down, your internal jugular comes up and it bifurcates. And does it lie on top or behind?
The jugular line on top and behind the carotid.
Right. All right. Goes down first between the bifurcation and the internal jugular. Then bifurcation of the internal and external carotid into the retropharyngeal wall. And once it starts to go, as you dissect it down up here, once you find your vein, from the time it passes your vein until it goes into your pharyngeal wall, it's about a half a centimeter. It's not very far, and you'll tent the pharyngeal wall up. And if you're not careful, I've seen boys dissect out a whole lot of pharyngeal wall and give themselves a big gaping defect there. Now, if you feel with your little pinky up there, right in the crease in the neck.
Yes. We might as well take the upper of the two creases then.
You suit yourself on that. Now you want to, there's the tip, see?
Uh-huh.
Right where you want to,
There's the anterior ball of the sternomastoid.
that's good.
Add some space.
Too bad you didn't get this all out in one nice pretty specimen, isn't it, huh?
Yeah, it would have been pretty good, isn't it?
Huh?
See, it would have been pretty.
Pull too damn hard. Clip, please.
Just spin that in.
All right, another clip, please. All right.
Excuse me?
All right. Isn't this nice surgery? Isn't it fun? What are you going over that way for? Let's go on down.
Well,
You got
just using
enough.
all of my skin scratch. There's no point in scratching the skin if I don't utilize all the
Let's have a
space.
clip, please. Thank you.
See it?
Yes, of course I see it. Let's go. Have a knife. Come on, let's come on through. Go down.
Hemostat. Fine body cut through there.
You're not down to the deep cervical fascia yet, are you?
I know, but if you're coming to the low vessel hair, then you'll have to...
All right.
Remember the two that I missed? You missed that.
All right, let's tie this and get some of this hardware out of the way.
This program comes to you live.
How are things going, Dr.
Fine. Captain.
What's your level of anesthesia?
We're about the second plane, third stage.
My old boss in anesthesia used to say, if there's ever any change when you're giving an anesthetic to a child, stop the anesthetic. If you think they're too light or too deep, stop the anesthetic.
That's peachy if they're too deep.
Well, it's still peachy if they're too light. Until you can regroup your kids.
It's a long time ago you're speaking about it.
Yeah. Oh, I don't know. That is fine cat cut.
That's where they used to give the kids a 22 bullet and shoot.
Oh, no. We used to use anesthetics that would tax your ingenuity, like ethylene. A very good anesthetic, but I don't know why it isn't used more often.
Causes bleeding.
So do we.
This is nice surgery. These are lots of fun.
The satisfying thing about this is that it's curable.
Yeah. That is, if you get the tract all out.
Well, that is known as the shaft. It happens at any time, night or day.
It depends if the surgeon dissects the tract out of the first
All right,
incision,
all right,
they
all right,
vultures
let's go to
it.
work, let's go to work.
Nice.
Come on, Doctor. You've got both hands in your mouth here. Now you're coming down
Adson's please.
coming out on what? On your deep cervical fascia, aren't you, huh?
I hope so.
All right. You know precisely what lies underneath there, don't you? Huh? You do? All right. You better. Ooh, what are you using the end of that for?
Let's see what is in here.
Well, don't use the end of that thing. Use little scissors or use the cutting edge of it. You just told me you knew what was there.
I'll be able to pass this thing through.
Very shortly
scissors,
you'll be
please.
able to pass it through. We're back to pecking and scratching. Boy. What's that? That looks like a structure, doesn't it? What could it be? What could it be? We gotta know. Alright, let's go on
Well,
through here.
I cannot identify it with confidence.
What's this on?
Same, the other end of the same.
Well, good for you, Doctor. Fine. Now, what are we gonna come down on? See, it's going to go straight in, isn't it, huh, Doctor? But pull on a little tension on it, gentle tension, and then feel where your track goes. You can feel it real nice. See? Hi, Jim. This is we picked it up here, and he's got it. He
Broke it in half.
He cut it in half. Never say you broke it in half, Doctor. In order to make it easier to dissect, he cut it in half.
I said we to be kind.
It's come along real nicely. I believe I can do it up to here.
I've had my hand held in here so far. I know you could do it as I've gotten this far.
Where this business about dipping down through the
It's going straight back there now.
internal, external
Let me
product, I don't
Let me
know.
feel some of that.
Go ahead. No.
A little
Oh,
baby
I'll have to
retractor
get back.
maybe.
There you go.
That's all right. I'll just keep my left elbow out of the...
Well, something showed up. What's that?
lymphoid tissues.
You should.
Incidentally, have they sent for the gallbladder?
Now, what did you do? We haven't got another one of these little retractors now? All right, if you don't have one, we'll do the best we can without it. All righty? Now, just stay close to the object you're removing. Spread and cut. Spread and cut. Up close to the object you're removing. Spread and cut. Stay close to the object you're removing. You guys can just always keep saying that to yourselves. You'll never get in trouble. But in dissecting something out, it's so easy to start drifting out, drifting out.
You're right.
That's true of the major blood vessels, too.
I have another one.
Sure,
All
they're
right,
going to specimen
all right.
more
Well,
with
then you better get started and get some blood on her then. Now you are getting about to the point where you must make a reevaluation
Yeah.
here. Because there's your bifurcation and there's you right down to your pharyngeal wall. See it pulsating there? Now you got this on this side to clean up.
Where's the bifurcation?
See it right
Yeah.
there?
And where's the bearing?
The pharyngeal wall is right there. It's tented way out. Look where it'll go if I let it go.
Oh, yeah.
See?
Yeah.
Now we could have someone put a finger inside the
No,
mouth.
now you could just go right ahead and dissect that damn stuff off of there that you can see has got to go on this side. See? Stay close to the eye. That's a baby. Good. Oh, you're cooking? Our incision's just a skosh too low, isn't it, huh?
Yeah, and I use the uppermost crease too.
Uh-huh. Very interesting. Now, how are you going to take care of this situation? Gonna have a tissue report?
First of all, I'll inspect our
Hi,
display of
Ken.
retractors.
Got a classical branchial sinus here that we've taken out the lower half, and now we got the upper half. We're down to the pharyngeal wall. Now, you can see your pharyngeal wall tending up there. You can see your bifurcation of your vessels.
That pole retractor might be better than this. Let me try that. Is that what it looks like, that little tube you're holding on to?
Yeah, that's it. Well, there's the other half.
The other half is down here.
We divided the other half to facilitate the section.
Another pole retractor, please. This is the action that we took a picture of. I love it.
There was no infection in it?
It's very nice up in that.
It got irrigated once with
Let's get the light a little
polymixin,
better.
and then it dried up.
Well, we never did it at all.
We need the light now like this, I'm afraid, huh?
You're just down to your pharyngeal wall right now. You can put a
I
stitch
know
through
it.
that at any
Ah.
time. You're going to have it off in your hand and not have a hole. You're going to have a hole that you're going to wonder how you're going to close in a minute.
Okay, I think that's about as far as we can go.
All right,
Okay.
take a stick tie.
Let's have a baby Ferguson or a French tie with a 4-row cotton, huh?
There you can see. Wait a minute, Doctor. Can we get the damn light a little better? For crying out loud. This is not satisfactory, not by a long shot.
It's shining up here on my hand.
All right, just get it down. Come on, come on, come on. Holy suffering Moses. Now it's all dark.
Okay.
There we go. That's a little better.
Good?
Yeah.
Little.
Except for my head when I lean over.
That's better. It's about... All right, now. Put it right. Take a stitch right down at the base there. Okay, way down as low as you can go. Lower yet, lower yet, lower. All right.
Pretty damn big needle, all things considered.
All right. Grab another forceps. Well, you didn't go low enough, did you, huh?
Perhaps not. A few millimeters, though, I think, is
Well,
what
tie
Dr. Gross
way low.
feels
Wait
is.
a minute, I'm trying to help you. Tie right, you can see it tending up there. Tie right down on the pharyngeal wall. If you can't see with your finger, why, a lot of competent doctors ahead of you have invented instruments that you can put in your hands to replace the big fingers.
You mean like a hemostat? Hemostat.
Nothing like the finger.
Well, sure, now, Doctor, pull, will you? Now, there's no light at all.
No, I'm in the way.
I would, well, get your head out of the way. Learn to lean back from the table. You got some other company here that puts his nose right down on a wound, too.
I see why you're... It's all being transcribed.
Guess I better be, huh?
Now you give your assistant hell, you see.
Another piece of the track. Now, here. Wait a minute now. Don't pull that damn stitch off, or then you will be in trouble. Pull it up a little bit. After all, there's a limit. Wait a minute. No, why did you let it go? Pull it up so I can grab
you had
it. No, I haven't got it. It's a defective clamp. Now, what are you going to do?
Well, I'm with a sponge.
All right, you got it licked. That track looked awfully obliterated, didn't it?
No. I'd still try and get a stitch in it.
I don't see how you possibly can.
Can you get it? You want
I can get it if you get...
You want a finger in the pharynx?
Wait a minute. No. That would make it easy.
This way we only have to suture the jugulars.
If we'd known, we would have put this child on bilateral carotid compression for a while.
Scissors. Scissors. Yeah, for that.
Collaterals. Collaterals.
It really is no good. I have to agree.
Now, wait a minute. You see, I've done something there, so you got to reevaluate things. Now. Clamp, please. Elton should be working here with his left hand. And it's right up. Long ways down there. That's not it. I would say this has happened in about half the cases I've done, and nothing's ever come of it. Nothing. Ever come of it.
Roach just cuts them across with a, there's your hole, caramelized knife, isn't he?
Well, now, do you drain
There's
these
your
when that
carotid.
happens?
Yes.
Yeah.
And it's right against the pharyngeal wall there, see? Can you see that? Well, now, who ever thought of giving us some light? That's where it goes, right there. There's the end of it.
Yeah.
And it's you just can't go down in that hole.
No.
But you've got the tract all out, right up to the pharyngeal wall. You know that. Now, here's where the forceps goes against the pharyngeal wall. I'll show you. See, here's where your not retract. There's your vessel. See it?
Mm-hmm.
See your carotid beating there? See it? Pulse rate's a little fast. And there's where your tract went down. See, right in between them. See? Right down in there, between your carotids. See it? And there's your pharyngeal wall. See it? And there's no gum chewer. I'll put the carotid artery away a little bit. And just sort of keep going up there. Now there's where it came off. See?
What is wrong with that stick tie we
Now
had?
just well, it was stick tied out in the middle third. I'd rather have it. Got another retractor there, please. Ah, thank you. Here, just hold that like that. I'll try to get the exposure he desires. I'm always trying to help. Right. There's your hole. See it? See? 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 See?
Uh-huh.
Is that right through the
Or look on the pharyngeal wall. See it?
Is
Yeah.
that right through the hole right through it?
It's right up to it, and then it retracts. It pulled out of the muscle, and it'll come right down over it, and close right over. But I drain them. I'll put a drain right on up that way.
Let's have a little baby Penrose, please.
Very nice. Very nice. You just put a Penrose drain up in there and bring it down
Bring it
here.
down through this one. With
24 hours, take it out.
with clips.
Ausmachen.
We can still bring out the Penrose between a subcuticular, couldn't we? And then we won't have to bother about clips.
What?
A subcuticular skin closure.
You should close the subcuticular skin closure around it, yes. And then you can, I don't like to use clips in children.
No, I don't like to put in anything that I have to take out. That's what I meant.
We've
So
been-
we can get a
We've been
Penrose.
using a subcuticular chromic,
Yeah.
not removing it.
That's right.
Yeah.
The question is whether you can use that with a drain coming out. You could
You
start
can
the
like-
you could start the subcuticular at the edge of the drain.
Well, you
and
could
run
do
it
it.
anterior.
You could do it on this upper one very nicely.
Yeah.
Yeah.
But the lower one, I would put in some skin sutures and take them out.
Well, I'll see how it looks when we
Plus.
get down that far. It might well.
Very nice. Very
Well,
nice.
thank you. Now you could flex the head back up a little bit. I'll take out the pad from under the shoulder. Okay, let's put it front right in the hole. Okay?
Recording on a 25-year-old white female with a prolonged history of rheumatic fever and cardiac involvement from the age of 11 years. On December 8, 1954, a mitral valve operation was performed. The postoperative course was complicated by recurrent fibrillation of the heart, but otherwise the patient convalesced well. She was discharged on digitalis therapy, aspirin, and penicillin. She was readmitted 1 week ago with a history of recurrent attacks of fibrillation and evidence of pneumonia in the left lower lung field.
The initial recording is taken from the apex. There is evidence of a harsh murmur in systole and evidence of irregularity of the heartbeat compared to the normal tracing. The second tracing is taken from the pulmonic area in the upper chest. There is evidence of accentuation of the second sound due to the increase of blood pressure in the pulmonary circuit, secondary to the valvular difficulty. There is evidence of some pneumonitis at the left base due to the rheumatic fever, with the production of rales, which sound like bubbles on each breath. Anita, tell me about how you got sick and how you've been feeling in the past few days.
Well, I started from about 6 weeks ago when it started. I got the flu-like, and then I had awful heaviness in my chest. And I called the doctor in, and he gave me a shot of Digitalis and a shot to pass my urine. And then it went away for a few days, and then on and off I've been sick ever since, coughing, kind of weak and hard for me to breathe good. And then this last week I got real sick with this awful thing on my chest and mucus and spitting.
How have you felt since you've been in the hospital?
I feel better, except I still cough a lot at night.
How do you like that cough medicine?
It's lousy.
For comparison, a heart sound tracing is taken from a normal 23-year-old male who has no history of heart disease and is perfectly well. The first tracing is taken from the apex of the heart. Since it is late in the afternoon and this patient is hungry, you can also hear the bowel sounds in this tracing. The tracing is taken from the pulmonic area. Here the second sound is normal because the blood pressure in the lungs is not elevated because this patient does not have a valve lesion. Recording of the breath sounds indicates that there are no bubbles or valves in this normal individual. The next recording is the heartbeat in a 30-year-old woman who has had prolonged history of rheumatic fever and rheumatic valve disease of the heart since the age of 10 years. These murmur tracings will be compared to murmur tracings which will be recorded next week after a heart operation to correct the leaky valve in the heart. The first recording is taken from the apex of the heart. Recording from another area of the chest indicates a different type of murmur because the patient has deformity of a second valve of the heart, which will be corrected at the time of the same operation. In this patient, the pressure in the pulmonary artery has been measured directly by passing a small tube from the vein in the arm around into the heart under X-ray. This patient's pulmonary artery pressure is normal, and in this tracing, the second heart sound is not accentuated. This patient has no pneumonia, and the breath sounds over the lung are normal.
Cough.
Now, how are you feeling, and tell us a little bit about how you feel about the heart operation you're going to have.
Well, I feel fine right now, and I'm glad that the operation is finally going to be done.
The final tracing is taken from the belly wall of an individual who is normal. The sounds that are heard here are the normal contraction and the movement of the intestines. By listening to these sounds, it is possible to tell whether there is obstruction of the bowel or inflammation of the lining of the bowel, indicating peritonitis. In this tracing, the sounds are normal but are very active because the individual is hungry and has just smoked a cigarette. The next patient shows no murmurs. This patient is suffering from rheumatic inflammation of the heart, and the sole change here is an increase in the heart rate. By increasing the rate of the heart, the body is able to maintain the demand for blood, since the heart at each stroke can only put out a small amount of blood due to the disease condition. The heart sounds here resemble a machine gun, and it is impossible to differentiate the first sound of each heartbeat from the second sound.